Okay, welcome to the Demonstrating Implementation Excellence stream at SNOMED CT Expo 2025. Thank you to IQVIA for sponsoring this stream. My name is Victor Medina. I'm Senior Terminologist and CSRM Lead Latam in SNOMED International, and I'll be your moderator for today's session. We'll address all questions at the end of the presentation, and for our online audience, please use the Q&A button to submit your questions to the presenter. For those attending in person, feel free to use the microphone provided in the room when the time comes. It's now my pleasure to introduce James Pennington from Barts Health NHS Trust, who will be presenting Navigating Complexity, SNOMED CT in Critical Care. James, go ahead.
Thank you very much, and thank you for SNOMED for inviting me to present today. So I'm a full-time adult intensivist and anaesthetist working in London, and I'm also one of the clinical informatics leads. And I'm going to discuss some of the challenges around intensive care data, which is in terms of volume, complexity, and the high acuity that we deal with, and how that SNOMED CT can help with the data to present them clinically useful, but also then it becomes analytically useful as well. So the challenge that we have is that we have patients coming from multiple areas and multiple presentations, and there is far too many, so much data presented. You can see from this just simple patient lying in bed. We have ventilator data, we have infusion data, we have renal filter data, we have multiple streams of hemodynamics, of vital signs, fluid input, output. We have medications, diagnoses, multiple teams, clinicians, multiple professional groups seeing patients, and we have multiple pathways through that element of care. And we're trying to challenge from a clinician's perspective. We're also trying to take from the notes that were handwritten, often ineligible, or certainly illegible, or is very difficult to read, and certainly extremely important, difficult to extract useful data from. Moving towards written notes, but we've then got a series of multiple note entries, and the ability to then try to aggregate that into a useful clinical story is the challenge. And so we then move towards problem listing of some sort of both acute problems, resolved problems, and past medical history. This is the model of care for healthcare that we have done for many years. The challenge has always been to extract that information in a way that we can usefully use. If we're essentially data rich but insight poor, and I suppose if this image belies the simplicity in that each of those streams could be many layers thick, and the average adult critical care patient might put in 100 blood tests a day. They may have thousands and thousands of physiological data points. They will have a minimum of 10 to 15 clinical notes, and you're trying to make sense of that. So what's the pathway through that? So the context of for where we are is that I'm part of Barts Health. We are a tertiary, quaternary group of hospitals, which accounts for about 1.5% of UK hospital activity, and about 2% of critical care admissions, and certainly for London, in my sort of home base at the Royal London, in the adult intensive care, we look after about 7% of adult critical care. Within those four groups of hospitals, we have one adult, one paediatric critical care. At the Royal London, we have 4 critical cares within St Bartholomew's Hospital, and then one at the other 2 sites. And that accounts to 160, 180 beds at times. And so that's a big scope of practice. But then I also work within a network, and that's both in terms of Northeast London, but also the wider network of London and Southeast England. So why SNOMED CT? No, I suppose this sphere group may find this very easy, but we're trying to take it the information from the bedside into the EHR towards coded, structured SNOMED coded warehouse data, and then present that in clinically validated, clinically controlled, useful data sets and dashboards. And then once well validated, to then forward it on to registries and the like. It's reason, complexity, comprehensive, flexible, but it also, the reason for my benefit as a clinician is the synonyms, the flexibility, ability to not actually force people to have to pick the same diagnosis code every single time. But also the ability, and this is the challenge is for some of my colleagues where we are paid by ICD-10 codes, or they're used for procedures coded in OPCS4, and so the ability to translate SNOMED CT into other systems is very helpful. And the biggest benefit, certainly for me, is the fact that it's embedded within the EHR. So I can bring the coding to the bedside, to the note very rapidly. So we're not having to do this remote from the patients or as a second or historical problem. So how we embed it within the workflow. So we have essentially you can start to type diagnoses, and it will offer a selection of terms, and it will allow you to pick a diagnosis or a problem or a procedure. And that will then obviously have the underlying SNOMED code within it. But we have some curated lists of common things within critical care, within systems-based. So for example, you can see here, I've got the respiratory system, and below that we have the multiple types of common critical care diagnosis. But one thing that's really made it much easier is the ability to code on mobile platforms. So we now have a mobile EHR, and I can then code and do that as part of my handover. Just curate the list, add further terms, put qualifiers, and we're getting added procedures and added problem listing straight there, because that's actually the way we then deliver clinical care. And then we take this patient story from okay, we have individual document types and dates, but actually we then have a blob of unrecognizable or at least very difficultly to extract data towards a series of diagnoses with time points and clear structured data points, problems, procedures, medications, and also to some degree pathology, although some areas are slightly more challenging, like some of the radiology reports. So we then we can then start to take that data and start to make decisions. And so, although this is some of the data that you can get from most hospital systems, I can drill down to our 60 critical care beds at the Royal London, and you can see the ward areas that we admit to, and you'll see a dip within August for some of the elective areas, surgical pathways, but for critical care. But then you can see that we have 3,300 admissions, 3,200 unique patients. But then the bit that's really good to know is that within that data set, we have nearly 30,000 SNOMED coded problems. We have 11,500 diagnoses and 16 and over 1,000 SNOMED code procedures. And the detail of that is that some of those, certainly for the diagnoses, they're clinically relevant diagnoses made in the moment, and so they are really they're the teams that need that and need to make their judgment on the clinical care based off that. But also the procedures are often, for example, procedures that were lost, were never coded. So if I do a bronchoscopy on the critical care, that doesn't come with an OPCS4 code, and that's not paid and coded in the same way. But because we do it in the moment, on the day, you get that information, and you get it, and it's then actionable and helpful. And so I've just picked out a couple of areas that show why having codes help is that our airway interventions, if you just write, allow teams to write airway interventions by name, you can have all sorts of of names and adjustments, abbreviations, spelling mistakes, and you get this certainly on this sort of plot. The multiple very low numbers of procedures done in the because that was a term that particular individual uses. Whereas as soon as you then map that to SNOMED CT codes, we then get much more robust information. So I can get the change of a tracheostomy tube, doesn't lose the one patient who it was just says tube tracheostomy or tracheostomy tube change. These simple human clinical relevant changes. But we can also then look at things like doing tracheostomy insertion and look at both the surgical, the percutaneous, the dilational technique, and analyze them in that way. I can also look at the inputs from my AHP colleagues. So we capture the physical therapy, the occupational therapy, dietetics, speech and language, and our psychology input for those patients on the unit. And then we can, but this then transcribes into their post-critical care stay, follow-up arrangements, and then coming back to clinic, so we can then see what their touch points were with the organisation and with the members of the team, and then make better judgments. The other things that we are mandated to is that certainly for the UK is all adult critical cares should be reporting to the ICNARC. So we have a standard data set that we need to curate, and we have a team of data analysts and data collectors. And historically, that was taking the A1 paper charts and capturing the information from there, writing it from one system into another system. And then as we've adopted EHR, and we've now got to a point where that information is aggregated face up, and so their job is much easier, and they can do more analysis and less just data transcribing. The same for the pediatrics thing, they report to PICANET. And the point that we're trying to get to is where that some of the routine audits, like the catheter-related line-associated bacterial infections, site-associated infections, or ventilator-associated pneumonia bundle of care, traumatic brain injury type audits that we would do as a major trauma centre, they are naturally automatically collected, automatically longitudinal audits. And so we can analyse it at any time point. We have KPIs that are left and we are monitored all the time, and then we can dive and repeatedly do these without spending the time doing the data collection. We're doing the analysis. So I'm just going to pick a couple of themes. And so one big area is frailty. And we have the ability within our HR of doing clinical frailty scores for most of the inpatients as they get admitted. And that then so we have a CFS score. Within that, we also then get coded frailty data. So we get mild, moderate, severe frailty, which for these critical care wards of the Royal London, I can now see across the last year and a half. I've just looked back 12 months, and I can now see how many patients will have some form of frailty, and we can then look at the equity of care they got. Do we, as an adult, as critical care, admit frail patients? Do they have the same outcomes? Do they have more complex discharge needs? And also, because they're frail, are we making the right treatment escalation decisions? So I then take some of that data and then look at our trust hospital system level dashboard, which we happen to use Click. And then we're looking at the frailty scores against the documented resuscitation plan, treatment escalation plan, and making sure that people who are clearly very frail have had that discussion. We're not denying them the ability to start to plan their care. And that really is that's important. Other thing extremely common within critical care is intensive care related delirium. And we have the ability to do scoring systems. So there are many, there's 4AT score. Within critical care, there is 2 very validated scores, the CAM-ICU and then ICDSC scores. And we have those, they're usually done at least once per shift. for the right patient group. And we have that captured clinical data points in the system. But then we also have that, so you can see I've got that back there. We've got the assessments by date for all of those areas. But then we can say, actually, based on that, have they then got a clinically relevant diagnosis of delirium? And that then has meant that we do now have an operational dashboard that's driving clinical ward rounds. We have a delirium ward round looking at interventions to reduce delirium. We have it's affecting patient care, and it's made it service improvement. We also are a very big trauma unit, so I can now look at trauma across the critical care. We are able to identify that cohort from the ability that SNOMED coded traumatic injury and other associated terms. And then you also see people doing other qualifiers to look at some of the complexity of running a major trauma centre. So we have major hemorrhage, we have major head injury, and then we have the other elements such as adults, paediatrics, other bits. And then we can look at the diagnosis per patient, per area, per month, and make insights. So the ability part of the problem is that this issue is that we've managed to make the change by driving it by clinical need. So our audit team couldn't do the delirium assessments and get all the information in a fashion that meant it possible to drive the ward round and drive patient care. So by getting the data in the right way and it's presented back to the dashboard that's updated near real time, we're then having a clinically led, clinically driven change. It's iterative. We've harnessed new technology adoptions such as deployments such as the mobile EHR, and we have a dedicated established informatics infrastructure, both at a hospital level, site level, and also at the critical care level, and as a network. So I think we've been able to measure value. We're looking now into some of the other completeness handover elements, and then becoming some of the, getting reproducible cohorts of data from the SNOMED CT coded data. The important thing for me as a clinician is making sure it's designed at the natural clinical language. We're not asking people to learn codes. They just need to write the diagnosis that they are using already. That means that synonyms are fine. It doesn't matter if you write PTSD or VAP, because that's then recorded, we will get that code and we can then make useful sets. Making sure that all the sets are small, that they are curated, reviewed, as terms change, and that there is a process of governance, and that requires, certainly at the moment, a 5-hospital system, will soon to be a 7-hospital system of change, and that has then made ability to then make quick, small changes. And part of the knowledge is that at the beginning, it's a data quality thing. It's completeness. It's making sure you capture the information. So what's coming up for us is getting those research and QI service improvement pipelines, looking at ECL cohort definitions shared across our sites, across our network, and then looking at how you present that back within the EHR, looking at the terms across the pathways for our patients. We work in a big network of hospitals, and so and multiple systems. So how we, by using clear terms, we can get that, and then be able to automate some of our registry submissions. I think there will be an element for machine-supported coding, machine learning, for some of our complex injury scoring, and so it would be lovely to put some decision support back, finitude-driven support back into the system, so that we can then drive care. And I will finish on the fact that certainly for me, SNOMED CT has transformed and continues to transform our critical care data. It helps me make better decisions. It's much easier looking at coded, restructured data than looking back through hundreds and hundreds of individual documents, trying to find out what was happening at any point. It's easier in the moment for patients who are current, but what if I want to look back at a cohort a year ago, 5 years ago, and that's very, very difficult. And we're working within a network of 60, 200 critical care beds, but we're looking at serving a population of 2.5 million.
Okay, thank you, James. And now we will begin the question period. And as a reminder, if you're in the room, please use the microphone to ask your questions so we can hear you clearly. Any questions in the room? Charles.
Thank you very much. I should declare an interest. I work in the same hospital as James. One of the things that really distinguishes intensive care units from other ward areas is that almost all of the care is delivered one-to-one by a nurse and the patient, and the doctors cruise around giving their fancy views and so on. Do you think what you've described influences how nurses work with those patients?
It definitely does, and it has made definite impact. So the delirium example, it clearly has, because we have delirium linked nurses. We have a group of people who are very interested, and they have understood the value of recording their assessments that get us a coded data point, and then we then record the clinically relevant delirium diagnosis for that patient. That has then meant that we then have a long-term ward round, we have a team, and we are not having multiple broadcast messages saying who should we see, how should where should we be deployed. We know which patients are delirious today on the unit. I can search now and tell you who out of my 60 have delirium, which is clinically relevant. And the real interesting thing looking through the coded data is the difference between what we as clinicians feel as clinically relevant and important versus what the coders have coded 6 weeks down the line, because there are many patients who get an element of delirium, but it hasn't been clinically relevant that's guided our care.
Thank you.
Are there any other questions in the room? We have a question here, and it's a repetitive question across these sessions. How do you manage clinician engagement and adoption of SNOMED CT-driven workflows?
Yes, so part of it is trying to, I suppose, design with the critical care team the elements of the change. So making sure that we go with the high impact area pathways first, being very clear what the measure of success is. So what is going to change for you? What's the benefit? So the first benefit for the delirium team was getting that information discreetly. For the trauma team, it's knowing their whole cohort of patients. So making sure that they see the benefits, the reason for the change, making sure that it fits within the pathway. So being a clinician, it's much easier. I took a group of interested people, and we confirm the change is practical, make sure it's not too burdensome, and then prove and basically show people how easy it is to do the coding, how easy it is to problem list, and go, look, why wouldn't you do this? My ward round is much more efficient. My care is much more targeted, and so you bring people with you and get the quick wins.
Thank you. Any other questions? We still have time for questions. So you're using free text and you're analyzing free text. Is that a driver for clinician engagement?
So the ability, I suppose, a couple of things. One is, we still have free text entry, data entry, and you're trying to read the last ward round or the last clinical summary and make sense of what was happening. I suppose that if you can avoid that and streamline that, it certainly helps clinical care. The one thing that's certainly making the discipline of writing or committing to a diagnosis is what makes a change. We're very difficult within medicine of writing multiple differential diagnoses, and so actually that makes it very very clear going, actually, is that what was happening, or was that just what you were thinking could have been on the breadth of things? Actually, no, we know this was what the problem was. We were treated that. That's why this intervention was done, and we then measured that outcome.
Interesting. Well, that concludes this session, and to our online delegates, you're welcome to remain here for the next presentation in the stream, or you may navigate to another session via the event lobby. Thank you, James, for an excellent presentation.